I think that it's fair to say AI is here and it will be supportive at this time and not more friction based. Would you agree? Yes or no, generally?
Yes,
Okay. And you're also suggesting that when we talk about prepayment, that nobody is going to be exempt from some internal auditing of that money. Did you use that money appropriately? Was it for medical necessity? Did you withhold them, care because you want it, right? We're never going to get rid of an auditing process, whether we call it prior authorization or let's look at those claims versus, how the money was spent. Okay. So you're agreeing with that one, right?
yeah, exactly.
Okay.
No, I think that's a fair statement.
So
Yeah,
I think we can imagine a future different than the way it is today. The key in leadership is things constantly are changing. And as leaders, we need to be aware of how we're going to manage this ongoing change to try to make it better. And physicians, again, are obligated by their oath to try to make things better for everybody, right?
definitely.
911, what's your emergency?
Hello, and welcome to the Fire Chief Podcast, the only podcast dedicated to the Chief Medical Officer. I'm your host, Lee Scheinbart, and this podcast brings you the hottest and most crucial conversations in healthcare and physician leadership. Today's show is brought to you by Belly AI, an AI-powered gut health app that helps you understand how food impacts feelings of bloating and discomfort. With features such as food analysis, personalized insights, and daily improvement tracking and planning, Belly AI makes it easy to track your patterns and to take control of your belly. As a lifelong patient managing Crohn's disease, I can honestly say that this app is a game changer. Download it today on the App Store. Belly AI. Our guest today is Dani Madril, a leading physician executive with over 25 years of clinical and leadership experience spanning payer, provider, academic, and military settings. Dr. Madril earned her undergraduate degree at Mercer University, her medical degree at Wright State Medical School, and her master's at Harvard's Chan School of Public Health. For her training, Dr. Madril interned at UNC, followed by her residency at the Naval Medical Center in San Diego, before ultimately completing a fellowship in pediatric cardiac anesthesiology. Later, the good doctor served as vice president and chief medical officer for Centra Medical Group, overseeing governance, provider development, and operational integration across 70 locations and over 500 providers. Today, she is currently serving as Market Chief Medical Officer for UnitedHealthcare and leads efforts to improve healthcare delivery through value-based care strategies and collaborative partnerships with providers and employers, with a particular focus on the total cost of care management and clinical operations. Dani, welcome to the show.
Oh, thank you, Lee. Good morning to you, and thank you for having me on.
Oh, it's a pleasure and it's an honor. And we were introduced by a mutual colleague who spoke very highly about your leadership and your mentorship as that individual was growing into the ranks of physician leadership. And you know who I'm referring to, of course. Yes?
Yes, sir. Sure do. A great person and a great leader.
Yes, and he is off to a great start at a new system. And unfortunately for him, he's in the snow and we are in sunny Florida, right?
Definitely. I'm happy that he's in the snow and we're not.
Agreed, agreed. Well,
Yeah,
we
it's
do
great.
have a lot of ground to cover with or without snowfall. And let's start at the beginning of the beginning. I want to walk our listeners through a little bit of your background based on your bio, where you established yourself as a physician leader in your roles as a naval officer, as a pediatric cardiac anesthesiologist, CMO for the medical group. At what point or how did you find yourself making this pivot to serve in the payer universe and specifically at United?
It has been an amazing journey, and that I think is the first thing I want to level set with medical students and residents and attendings that young attendings, right, that hear my story is really it was that willingness to be listening to not just what the patients needed, obviously working clinically for 20 years as an anesthesiologist, but also then thinking, what is happening in healthcare around us and how can I affect that? And it's never too late, right, to change career paths so that that is really after I had spent my time with the organization as the chief medical officer. I realized there was a push and pull. As things happen in health systems, administrations change, and the alignment and strategy may not be exactly what you had envisioned. And also, I'm a part of the sandwich generation, so I started thinking about, how I would get closer to my family, and that's how I ended up finding the position as the South Florida medical director for UnitedHealthcare, and was drawn to that because it really, for my point in life, was where I needed to be. And so again, it's being attuned to the skill sets you have, the tools that you've been sharpening, where your experiences are pivoting you. And that's what helped me get my position at UnitedHealthcare as a market medical director. So hopefully today I can share a little bit about really what my roles, responsibilities really align to at UnitedHealthcare.
Yeah, we will absolutely unpack all of that. And I appreciate right out of the gate the honesty of families go through changes. So healthcare goes through changes, family goes through changes, and
Exactly.
you have to align yourself to be the best version of yourself, whatever life throws at you.
Hmm.
And I think people still have notions that once you become a physician, you're supposed to practice until you physically are completely unable to do that. And I think that the world is moving too quickly to hold on to that. And God bless everybody who can. But life circumstances will create a demand. And I appreciate you being honest about what influenced some of these decisions. And yeah, most of our listeners probably don't understand what anybody does at a payer universe. So we're going to unpack all of this. Okay.
Definitely. I think it's great. I really appreciate the opportunity.
Well, let's talk a little bit about as you began to think about where you were in life and what you could bring of value to people. I'm sure your former anesthesiology colleagues and your partner physician administrators at the medical group, what kind of reactions did you get, good, bad, or indifferent, as you began to navigate the next step in your career?
I think the first thing is that they were surprised because I had been, clinical for over 20 years, and I was very good at what I did, and humbly am thankful that I had a very good clinical career without untoward things happening. So they were shocked that I would pivot from a position that I felt so comfortable in, right? And I think that's the other thing. I was very comfortable in the role I was in, and I felt good about what I was doing. So my anesthesia friends were not shocked, but more surprised. I will say that when I went to the administrative side, everybody calls it the dark side, and it was comical because once I started interacting and building the anesthesia service line and really learning that as physicians, we have to be physician executives, and what we say and how we act really is a presence that can influence a health system's decision. So as I transitioned to the CMO for the physician group, I learned that there was a lot that I didn't know, and that's the other thing is that willingness to always keep learning is something that we as physicians really need to work on because a lot of times, again, we get comfortable in our roles, we get comfortable in doing what we do well. Life challenges, as we've mentioned, occur, but really, as the chief medical officer, learning all about provider compensation, learning about provider behavior, seeing what the health system was seeing physicians do, right, and advanced practitioners do within the four walls or the buildings. That was eye-opening to me, really learning that perspective. And so when I left there, originally, when I left the administrative side, I didn't even know that I was going to have a job, which was kind of comical. So once I kind of had my position at UnitedHealthcare, they were actually complimentary because they knew that I have always had this huge desire to learn more. And by learning more, I can help affect healthcare much more substantially and help. I always tell people, like, you never know when you're going to be the patient. And unfortunately, or fortunately, the last couple of years, I've known what it is to be the patient. And you never, even as a as a caregiver, as you take care of elderly parents, you don't know everything that's going on as a physician. So that was the other thing that was has always been one of my guidance is how would I treat my family as a patient in the health system or even on the payer side now. And that's really where I think a lot of the people have been supported. My colleagues have been more supportive than shocked and angry. I have, there are some people that still find the payer. I mean, if they thought administration was the dark side, the payer is sort of like Darth Vader and the end of the universe. And it's really not that. And that's what I'm learning now through my 3.5, almost 4 years at UnitedHealthcare.
Yeah, some of these are pretty traditional reactions, right? The
Hmm.
surprise, gosh, you're so good at what you do. And I
Hmm.
and I received a lot of that from my colleagues as well. My partners were pissed because they had to pick up the extra call, and my patients were super angry because I was an oncologist, and you get bonded, whether you like it or not, whether you can or cannot compartmentalize. There's no getting around that. So you get through all of that, and then you come to find out there really is no dark side. There's no sides. It's an ecosystem. And your comments about taking care of your family or taking care of yourself, look, physicians are quite capable of learning. Otherwise, you couldn't even make it through school. So the capacity and the willingness and the desire to keep learning certainly is an attribute you carry into your administrative role. And then when you start taking care of a family member, sure, you understand a glucose, you understand a disability, like the basics. But when you start getting paperwork around the, management of the payments related to the person who needs care, that is a whole new education for most physicians if they themselves have not been patients or haven't taken care of anybody
Exactly.
with significant health needs. So that's when you realize it's just a ginormous ecosystem and we all have a role in it. And to me, I find it very unfair. And I understand the emotionality of it, but it's just unfair to position ourselves against ourselves, whether on one side or the other. Now, there's a lot of bad things that happen among physicians inside healthcare and whatever side you want to call it. But that's not the topic of what we're going to get into today.
A lot of work.
Any thoughts or comments about what I just said?
No, and I think you're right, and that goes back to how do we get a group of physician leaders that can have those difficult conversations, right? And physicians, we tend to be very independent. And anesthesia is the prime example, right? We're one-on-one with the patient. We tend to have relationship with the surgeon, maybe the ICU and the primary care specialist. But at the end of the day, we tend to be very individualized, and being able to have conversations and difficult conversations sometimes about behavior, actions, or inaction is always difficult. And I think you're right. I challenge everyone to learn more about that if as you develop your leadership role.
Well, so that fits perfectly with the next question. So as you're moving through that career and you take on the medical group and now you take on your role at United, and I know you've earned your master's. How did you begin to prepare yourself for this transition and either unlearning things or learning new things you just hadn't yet experienced at 20 years at the bedside? How would you advise people to get prepared for these roles?
First of all, I think the most important thing to do is realize that every experience you personally have in your journey, good or bad, is a learning opportunity. So I remember myself as a little junior officer in the Navy, and we were responsible for a lot of different areas at the clinic. So, we had to learn how to run the pharmacy, run the lab, run different things. And that it was cumbersome at the time as a young physician because I just wanted to do what I needed to do, right? But you learn from those things, and then you learned how, or at least I learned how to lead people, how to have those conversations, how to research the information, how to be the SME, right, the subject matter expert for whatever came about in the areas that I had to manage. And then I transitioned to academics and private sector where I worked on my own. So a lot of what I learned in the Navy kind of stayed in the back of my head. And as I matured, again, family situations change, kids are growing out, out to college and whatnot. I realized that I had a hunger to go back to the leadership opportunity. And that's when I went back to the School of Public Health and got the master's in healthcare management. And I didn't even know what to expect. I just knew that I was hungry to learn the business of healthcare. And I love how you say ecosystem, because I use the same term occasionally to explain to people that all of us live in an ecosystem. It doesn't matter whatever business you're in or um, whatever specialty you're in. There's always an ecosystem that drives your behavior, just drives how you respond and react to situations. And that really is what I learned at the School of Public Health is, the business side, how to have those conversations with the CFO about, what's the P&L, what is my service line? What do we cost to the health system? How do I bill? All these things. So learning every step of the way, every experience you have, good, bad, or ugly, is an opportunity to learn and hone those tools for your toolbox to help you be a better leader. The other thing that the School of Public Health did for me, and I chuckle because most people that meet me think I'm an extrovert. I am an introvert. It's so much energy to get out there, motivate people, but the School of Public Health showed me or made me realize that if I didn't do it, who was going to do it? Number one. And you need to get out of your comfort zone a lot. Like you got to put yourself out there. You got to put yourself at risk because other people may or may not pick up the load. To your point, like my partners, I felt bad. I left, and yes, they had to do more clinical, but at the end of the day, you have to put yourself out there. You have to be willing to work collaboratively with so many different people, and that's the other thing I learned at the School of Public Health.
Yeah, there are two parallel themes I want to unpack for some of our younger listeners and make a suggestion. One is learning how things work operationally, like you did as a junior naval officer. Boy, I tell you, if I was the CEO of a health system, I would want to hire physician leaders who ran a lab, ran their practice, ran a group. There's no substitute for learning in the school of hard knocks about how things go. So if we take that little parallel universe called the OR, sure, you know your role, you know what the machines are doing, you know what you're monitoring, your team knows, your surgeon knows. But did you ever think about what that stuff costs and the time and the labor and the educational requirements of everybody in that room and what's coming next and who's paying for the new OR build out and the next robot is too big for the square foot of the room? Like, I'm not joking here,
No,
right?
no, no, but you forgot one very important thing though, EMR, right? How do
Yes.
we deploy the electronic health record, which was another area of my kind of experience and expertise that I don't even share sometimes with people, but to your point, like you have no idea the work and the lift and the governance that goes through there. And that's really what I loved and still love because I learn it every day at United with UHC too. It's like governance is the key and the structure. You can have a great idea, you can have a strategy, but unless you're able to verbalize it, communicate it, and then operationalize it, and let's not forget that we also have to measure it. So the measurement component of everything that we do in all areas, right, clinically or administratively or on the payer side.
Absolutely. And so, the younger physician, as you get older, you get more seasoned. You walk into the OR and it's kind of like the Wizard of Oz. I mean, it's kind of like magic. Everything's there at boom. Well, that only took about 16 months of planning to make sure that everything was there for you and your team to safely take care of somebody who's vulnerable. So there's that element. The other element is I think leadership requires an individual to stretch out of their comfort zone. I think that's just a sine qua non. I mean, you have to do this. Now, whether you're an introvert or an extrovert has its own issues related to that. And I guess I do want to ask you, do you have a mental definition of what you believe an introvert is and what an extrovert is? So we can talk about this stretching for just a moment.
Definitely. So in my mind, and again, not the perfect definition, but an introvert is someone that gains their energy on their own, reflective, kind of assessing what transpired through the day, or an event, and needs people, right, to validate certain things, and has a smaller group of I call my board of directors, right, smaller board.
Yes.
For me, the extrovert, and I always use my husband as the example, he retired after 30 years in the Navy, was commanding officer, had a lot of responsibilities, but he gains his energy by being out there with the people. So he would be with his team, and he didn't need that, day of going back and reflecting. He needed to go out into the people to get the energy. And that's sort of where I put introvert, extrovert. I love people, obviously, humbly say that I get my energy from being alone or a very small group of people, but that's my definition. I'm not sure it's right or wrong, but that's how my brain goes around it.
Yeah, there will be experts who will claim right and wrong. I'm not one of them. I fundamentally agree with both of your definitions, and I do remind some of the students in our Chief Medical Officer Academy class. It is not that being with people actually drains the introvert, because we're not talking about what drains you. It's where do you draw your charge? Where does that battery get filled up so that you can do everything else? And the reason I wanted to explore this with you is introverts can be outstanding speakers, lecturers, presenters in a boardroom, and one has to overcome their fears of public speaking or difficulties, but has nothing to do, at least in my own opinion, of being introverted or extroverted.
Totally
But
agree.
okay. And so the thing is, what you're stretching is not that I don't want anybody to come away thinking you have to become an extrovert and stretch. No, you
No,
have to find where you've been uncomfortable, which is presenting to non-clinical leaders or going back to the physician leaders when you used to work side by side. Now you have to present something to them or gain consensus with them. And that stuff is hard to do. And that's the stretching, regardless of where your energy is derived from,
I
right?
totally, that is spot on. And I love that you broke it out that way because it does help. I think for younger people, it's not that you don't want to be out there, you just need to practice, right, and stretch yourself. And I work a lot on that. Is like every presentation is um, really an effort, right, in the practice of being able to verbalize the presentation well. And the other thing I would say for people too is you are much more comfortable when you're prepared, right? So you have to put the work in and do that prior to really imagining any success.
And that's where I think physicians have a distinct advantage. The training and the rigor of what we go through, we're automatically capable as a result of that of retraining and practicing and retraining and getting better at any skill thrown at us, so to speak. So good. Okay. We've established the background. We've established some leadership principles. Now let's get into the world that you are living in. And I'm going to start with kind of a broad, generic question that we've danced around a little bit, right? So everybody out there that's practicing medicine has faced something called the prior authorization. There's no getting around that in the ecosystem. Particularly, we get into a lot of opinions about what is a PA and denials and the processes of reviews and appeals. And I guess what I want to hear our listeners to hear about is your historical knowledge of why even these authorizations were implemented in the first place. And then we'll start to get further into this stuff. So
Okay.
what's the history on prior authorizations
So
from
I
your perspective?
right. So I will kind of work my way into the answer, and I'm sorry if I get long-winded, but I think first of all is, knowing the history of anything, right, is and getting educated is the key. And how I've been working with medical students and residents now, really learning how we came to manage care and the environment we're in now. And so when we look at why we even exist as a payer, right, is making sure that we can I always think of it as access, right? Because we're working with networks, so making sure that we have safe, quality care that we can get to, our members or patients can have access to. The other thing is, it's difficult to really understand with all the clinical information that's coming out nowadays, what is medically necessary and what is clinically based evidence and practice. And you could be the expert in your area, but there could still be a lot going on that you're not up to date with. So I think that's the other area where the prior auth comes into play. And then when we look at the cost of healthcare, right? so many things drive the cost of healthcare, and it breaks my heart because it's not really what the physicians and their offices are getting, right? So when I think about the prior auth, it was originally a checkpoint. How did the insurance company validate that whatever the member was going to get, either a treatment, a lab, or a procedure, was actually something that would be safe, clinically appropriate, medically necessary, and cost effective. And that is something that as a clinician, you just want to do what you think is right for the patient, right? And the hospital system has their alignment about what they want to do. And I think this is where, the payer side of the house really is trying to manage resources, and that's where the prior auth kind of gets its footing in our ecosystem.
Yeah, I agree with everything that you said, and when we go through our medical education, I'm very pleased to hear that you're working in med ed and the GME side as well. But because most of, at least you and I back in the day, it was not a heavy topic in our conversation. We'd get a brief lecture on health systemness, but we wouldn't get a lot of information. And in fact, we got the opposite, which is you need to be a competent, capable clinician. People's lives depend on it. And don't waste your time thinking about all this other ecosystem stuff when in fact it is a fixed resource. And for those who come out of their training and simply just want to be a doctor, totally fair. But that's a little bit of a head buried in the sand a little bit, because the world is much larger than you and your partners. It is full of dynamic change and limited resources. So the real question and the real debate and the real passion and energy is, how do those resources get allocated in a fair way? And I think that you gave a nice description of, we just want to do the right thing, and the emotionality is when people accuse each other of not doing the right thing. And this is where this friction, which leads to the next question, is all this tension and this friction builds up. And so I wonder if you're able to speak a little bit about, do you suspect that we will see some reduction in some of these frictions, these processes that might have gotten a bit overwhelming for the average folks that are at the bedside? And where do we think those workflows and those processes may go down in the future?
Absolutely. I know at UnitedHealthcare, we've been leaders in how prior auth is looked at, reviewed, and checked since 2023. So the volume of the prior auth has decreased by nearly 20%. And that work, it takes so many different people, none of which report to me or do I see them every day. But we have to learn as market medical director that these possibilities to improve provider and member experience exist. So the prior auth work, I think, is going to be game changing, right? So the America's Health Insurance Plans are working together, AHIP, to really improve the transparency of what drives prior auth. United Healthcare is the leader right now with the gold carding program. It's over 500 codes that if you're a physician that has been demonstrating for 2 years that over 92% of all of your requested prior auths are approved, then you get gold carded. That means that provider or facility really just needs to notify us that this care is going to be requested, and that is something that should help all of us, right? The problem is back to education, because what we struggle with is what information, given the person's health plan, is required for an approval, right, and a prior auth. And what I find, again, my role as a market medical director is to really work and deepen my relationships with the health systems, the providers, and any healthcare practitioner within the ecosystem of now it's the entire state of Florida, to really understand what are pain points for them. And when I meet with them and speak with them, we all are struggling with staffing constraints. So the ability for that documentation to be submitted and have all of the key data points that need to be done for an approval sometimes are missing, right? And that is, when you look at the burden of why things get denied and claims, most of claims, and again, that's at the tail end of post-service, 93 to 90, I want to say 90 something percent, 93% are approved. So there's really no problem with that initial 93% of that volume of work. It is getting approved. But of course, all we hear about are the ones that are denied. And when we step back and look at those, a lot of the denials are administrative denials. No clinical eyes have actually touched that review. And it's sad. And clinical denials, for example, are they send duplicate requests or they put the wrong member's name. Right. So there are administrative things that happen that lead to a denial. And to your point, a lot of information gets changed, a letter gets dropped, but who reads that letter? Who knows how to read that letter? The physicians don't have time to read that letter. It's usually their office manager or someone, or someone gets it too late in the process, right, to really know what they have to do next steps. So I think prior auth, there's a lot of work going on. The main thing is really educating our members on how to use their health plans. That's a whole other conversation we can have one day, is understanding a health plan. And then for the providers, understanding what really needs to get included for an approval. And I have to say, I'm impressed that a lot of offices do know, right? Because they're experts at their area. So I think, and then the other thing is understanding when there is an abrasion. There are providers, or I would say myself as the chief medical officer in the market, where the provider can do outreach to me. The reality of it is I can help review or escalate to the right person when there's some type of abrasion in different areas of a care journey. And that's really what I hope today I can have people do as a takeaway, is that really seek out your payer market medical director. They are people that are really here to collaborate with you and facilitate care journeys for the members. We don't want the abrasion. No one wants that. And in reality, any kind of abrasion that gets escalated is a cost driver for all of us. It costs your team, right, to do the work. It costs our team to evaluate. When at the end of the day, that 93% that gets all the way through claims appropriately without problems, that's where we all want to be, because that is the most cost-effective care journey that we can give our members.
Yeah, yeah. Listen, you and I are able to talk about this as colleagues, and as seasoned physician leaders. We certainly will not be able to solve the problems, but I think you've articulated a few things that I remember in practice. In order for me to be the best physician, I had to go from room to room to room, and so I would immediately say, "Go ahead and let's get this thing going." And somebody not named Lee was working on the paper back in the day, faxing it back in the day, or once we got our electronic health record, putting in all this. And I guarantee you we got it wrong 85, 90% of the time, because for me to be the best Lee, I had to go to the next room to see the next patient with lung cancer and not stand there or do it at night when I didn't have all the information that I needed. So you're absolutely right. And it was this I call this law of unintended consequences that has upside and downside depending on where you are. And I think if we can begin to unpack all of that abrasion, all that friction, all that the processes got in the way of the processes, which got in the way of the processes, we need to dial all that back. And I think physicians, they get disconnected, one, because of their education, two, because in the old fashioned fee for service Medicare, you didn't do all that. It's stuff got done. But in fact, the payment was not great. And we all need to understand that Medicare has been failing to pay the American physician at a reasonable rate for a really long time, which puts great pressure on everybody that isn't a Medicare payer, meaning United and all of the others. So now the demands on the payer universe changes, and that demand creates a set of rules of engagement within the ecosystem that becomes very circular and very difficult. Now, I believe, and I'm not going to ask you to go on the record, I do think AI is going to help the physicians, especially generative AI, where you can get the information properly sorted in the right way. And hopefully there are less mistakes because it won't be error free, and the processes will get smoother and faster. And then the paranoid science fiction guys think it's just going to be an AI talking to an AI talking to an AI. Nothing will get done. That's speculation. I think that's a waste of time to go down that road. But here's an idea that we should talk about. And I think I mentioned this to you before. If the world could get to a more predetermined prepayment system instead of fighting for every nickel and dime on a fee for service, and all that money was shifted, which goes with all the risk too, to the physician side, would that reduce some of this abrasion and friction on prior authorization? Say, look, here's the bucket of money. You guys decide what's right and wrong for your patients with this bucket, because we have the same bucket. We're just sharing the bucket with you. Have you any thoughts about how we might reduce the friction in a more, prepayment model?
Well, I love the way you said you divided your thoughts about AI because I think sort of like the electronic health record when it hit us, right? We thought about the good, bad, and ugly, and then it became, in my mind, it just became a web that got us worse, and we ended up with a lot of cut and paste and nothing that was logical and trackable, which I think we're still suffering from. And AI, I see kind of hitting the scene similarly, right? So AI can do a lot of things. It can support the physician during care, right? There's a lot of that AI that can happen within the four walls that does the dictations. It can do all of these things. And then we have the electronic health records that have the AI pop-ups, right? This is what you have. Here's your differential diagnosis. Let me be, I call it the ancillary brain, right? We used to carry it in note cards. Well, now it's peppering us on the electronic health record. So I think to your point, there are areas where utilizing AI is going to be beneficial. And, will it take away prior auth? I doubt, because it goes back to my thought process of prior auth was there for a reason. It's there to make sure that there is medical necessity. There's there to be sure that it is, safe. And then you want to make sure also that there's no incidents of harm that could come to the member, right? So prior auth is there to really assess if something is needed. So at the end of the day, even if we change it, and I look at it, the accountable care organizations that we're in, they're not exempt of prior auth, but they have their bucket of money and they have their risk. So I do agree that the risk to the physician may help, but I don't ever see prior auth going away. Again, medical technology will be changing, so there'll be automation that will keep you up to date about the things that are in the works or that are newly approved. So the AI may help you understand that. I see AI more as a support tool and not a decisioning tool. So we're not using it at United for anything that would decision anything or adjudicate a prior auth or any type of claims, right? Denial. We're using it to really enhance how our members are being supported. So that is like care coordination through some AI, calling for claims because of AI. AI may help you address some claims issues earlier. So I don't see prior auth going away. I do think fee for service should be decreasing and going away and adding more value-based care and managing more our populations, right? Population management. Will we get there before you and I retire? Not totally sure, but it is a dream that could possibly help all of us work better in the ecosystem.
Yeah, yeah, nicely stated. So let me give you a couple of lightning questions, and then I've got two sort of bigger questions to wrap us up with. So I think that it's fair to say AI is here and it
Mhm.
will be supportive at this time,
Yeah.
and not more friction based. Would you agree? Yes or no? Generally,
Yes.
okay. And you're also suggesting that when we talk about prepayment, that nobody is going to be exempt from some internal auditing of that money. Did you use that money appropriately? Was it for medical necessity? Did you withhold the, care
Hmm.
because you want it, right? So I think you make a very nice statement that we're never going to get rid of an auditing process, whether we call it prior authorization or let's look at those claims
Hmm.
versus, how the money was spent. Which then, okay, so you're generically agreeing with that one, right?
Yeah. Exactly.
Okay.
No, I think that's a fair statement.
So I'm thinking in my mind, maybe there's a future universe where there's much deeper collaboration. You're sort of hinting at this, but I don't need you to be on the record about it. Just generally, would you agree, yes or no, that the more that large medical provider systems work with the payer systems to define the rules of engagement about how the money is spent and on
Mhm.
what is it spent on would be a better, less abrasive universe going forward. Does that make sense in any way?
Yes.
Okay. All right.
Yeah.
So I think we can imagine a future, whether we make it there or we're retired or we're gone, it will look different than the way it is today. And I think that's the key in leadership is things constantly are changing, at least in our lifetime. And we're, as leaders, we need to be aware of how we're going to manage this ongoing change
Mhm.
to try to make it better. And physicians, again, are obligated by their oath to try to make things better for everybody, right?
Definitely. And I would add to your comments that, the role of the medical director, market medical director, how I envision it, is that I help facilitate those collaborations, right? Because there are groups and health systems that are very savvy at starting to incorporate AI. We may not know about it, but if I speak with the CMO of that health system or I speak with whoever's leading that initiative, it helps us partner sometimes into exactly as you mentioned. How do we make it better for both of us? Because that is where everyone benefits, especially the patient at that time. And then the physicians and the caregivers that are at the bedside, anything that we could collaborate together to improve that, which is why one of the reasons I joined UnitedHealthcare was I looked at the mission statement, right? And so that basically you're trying to get the member the right care at the right place while providing ease of use for the physician and the facility, right? And then to me, that was like, wow, that's a win-win for everyone. Again, one day I'll be the patient, and I was definitely the provider. And so I think that's where my role is really to help that collaboration be established and hopefully down the road lead to, this imaginary world where we really collaborate a lot more utilizing all the tools we have.
Yeah, yeah, I fully support that, and that's why I'm encouraging, and that's why I do what I do to help folks like you in your role and those to follow. We need more physicians in all of these places in the ecosystem. We want the Lees and the Dannies to be focused on judgment and perception and empathy and outcome with the patient, and not using extraneous, unpaid or underpaid time with process and paperwork. That's what you and I do. We are the overhead. We will do that work so that you all can get to the room to room to room and do the things that that human being is expecting of you,
Expected to.
and your frustration level goes down. And I'm hopeful for that. And I've talked to another physician leader who said this is primarily existential. I said, why are you doing it? Why are you doing AI based chart review to help the people in your clinic do a better job taking care of it? It says existential. He goes, I'm going to be that patient in that clinic room. You will be, and I will be. So some of us have to take responsibility to make the system better, even if it won't happen tomorrow. Maybe it'll happen later on. So let's focus on one big question that I'd love to hear your thoughts on. Since we're sort of future facing, we've gotten a little sci-fi here. What do you think future physician leaders need to have in their toolbox? What do they need to display as this world of ours is changing and we hope for a better world? What kinds of things you want to share with the listeners about leadership tools?
The first and foremost is the humble servant leader. And with that, realizing that you're taking care of a patient, focus with your patient and show the empathy because that will never be replaced. Those relationships that we have with our patients at times that are critical, they're not, it's not a happy time. They're usually seeing us in healthcare. So, number one, you're going to have to keep your own humanity alive and well, nurtured, and be able to share that with your patients. And then once you're done, with the one-on-one patient care, you definitely have to be adaptive. You have to, be willing to learn data, be literate on what's coming up in the future, what are things in the pipeline, being aware of what your health system is planning to do, right? Knowing the environment in which you're working and your willingness to collaborate either internally with your own organization and maybe your department and also externally. And that as you pointed out, it's not even just the payer. How do you collaborate with medical societies? How do you collaborate with government agencies? You didn't even touch on CMS, but we've alluded to it a few times. How do you get involved? That those are three other things to put on top of what you're doing. But the humanity of being a doctor, no one's ever going to take that away. We can have extenders, we can have AI, we can have all of that. But at the end of the day, it's your relationship with the patient that matters and is the critical point. And really, as physicians, we're the only executives in healthcare that have had that responsibility. And it's not a responsibility that we should take lightly. It's a responsibility that people have trusted us with their lives, with their loved ones, and that we can't ever grow out of. That we need to grow into. And the rest of the stuff falls into how do you continue to improve, not just for that patient but for a population, right? Where I think is the future is really looking at populations and how do we support each other.
That's beautiful. Well stated. And I appreciate all of those insights and everything you've brought to our listeners today. Any other last thoughts or words before we wrap up the show?
No, I just want to thank you today for having me on. I really am humbled by this opportunity, and I really appreciate your time. The questions were very thoughtful. Anytime that anyone has questions about their payer, please go to your market medical director. Find us. We're always willing to work with you and make the healthcare journey better for everyone.
Well, there you go. Make the healthcare journey better for everyone. Find your resource and use it well. Thank you, Dani. Thank you for being
Thanks.
on the show. It has been great to have this conversation with you, and I'm excited about the future. And I do think if we are more adaptable, as you suggest, things will get better one way or the other. It's existential. Ladies and gentlemen, you've been listening to the Fire Chief Podcast, the only podcast dedicated to the Chief Medical Officer. Once again, today's show was brought to you by Belly AI. Download it today on the App Store, Belly AI. Want to learn more about what the world looks like from the desk of a Chief Medical Officer on the payer side? Then connect with Dr. Dani Madril on LinkedIn. You want to learn more about leading as a CMO no matter where you go in your career? Then check out our website, thefirechiefcmo.com, and connect with me on LinkedIn. I love talking with CMOs from all over the world. So get out there, call up your regional medical director, be a leader and be a chief. And remember, whatever you do, in the words of Sergeant Phil Esterhaus, let's be careful out there.